Hi, my name is Professor Chris Frey and I will talk to you about adult hip joint pathology. I think it's best to first look at what types of joints are in the human body. We've got practically three types of joints. The first one is a fibrous joint, a cartilaginous joint, and a synovial joint. Synovial joints are the most common joints in the human body. To look at a fibrous joint, you can look at the sutura in our skull. These are called synarthrotic joints. Syn means together and arthros is the joint. These joints mainly have a larger surface area. They go zigzag from one side to another, and there's hardly any movement at these joints. This is also the joints that keep our teeth in place, as well as the joints where are between our interosseous membranes on the long bones, like here on the forearm or on the tibia and fibula. Cartilaginous joints are either hyaline joints or fibrous joints. The hyaline joints are usually during our growth. They get later substituted by bones, and they are usually on both ends of the long bone. A typical fibrous joint would be the symphysis, like you see here in this picture, or an intervertebral disc. The synovial joints is here on the hip joint that you see there, and this joint consists out of five things. First of all, the articular cartilage that you see there in white, the smooth white part. The second thing, it is covered by a synovial membrane. This again is covered by a fibrous articular capsule. And when we cut through both things, through the capsule as well as through the synovium, then we find underneath a joint cavity, and this joint cavity is filled with synovial fluid. Let's now have a look at the different conditions. So this is a schematic drawing of the hip. So what I outlined here is the bone. So this would be the proximal part of the femur and the acetabulum. And the femoral head, as well as the acetabulum, is covered with cartilage. This is shown by that blue line here. The cartilage is covered by the synovial membrane and the synovial fluid here in yellow. That helps with lubrication of the joint. And the first disease that I'm going to look into is osteoarthritis. Osteoarthritis is like a wear and tear. Think of a tire. When the tire is a new tire, it's got a good profile and it runs well. But when the tire wears over the years, the profile comes down and the tire will give you a problem. The same wear and tear happens with the cartilage, in this case the osteoarthritis. So this is a disease of the cartilage. You see here that the osteoarthritis first flakes a little bit, but then there's areas that can break off. But these areas are more in the wearing area of the joint. So they wear more upwards where the joint is loaded, not so much to the medial side. This can then progress, and eventually you will feel that the leg becomes shorter because the cartilage is worn off, and by that amount that the cartilage is worn off, the hip then moves upwards. This can affect the gait. And then secondary changes are that there are small little cysts in the bone, and these cysts are very close to the cartilage. and they are on both sides of the joint. So they are on the acetabular side as well as the femoral head side. Now, as a reaction of the wear and tear inside the joint, the bone forms osteophytes. These osteophytes can be on both sides, on the acetabular side as well as on the femoral side. Now they look like noses here, but what the idea of the bone is to make the joint actually larger and cover it better. So here I'm going to show you a quick video of how this disease goes. So here we've got the white part, which is the cartilage. And this would be good cartilage. You see a hip and abduction and hip inflection, as we would be sitting and standing or sitting and walking. And now as the disease sets in, you see it first starts slowly on the cartilage. But these areas can go bigger, and then they eventually cause destruction of the cartilage, and they form out those bony spurs. These are called osteophytes. So the three things that are important of this disease is narrowing of the joint space, the cartilage wears, cysts formation, excuse me, as well as osteophyte formation. Here I'll show you an X-ray. You can see that, let's have a look at that left hip here in front of us. You see that the joint space is worn. You see osteophytes on the lateral side, on both sides, femoral as well as acetabular side, and you see a multitude of cysts inside. Here I enlarge this area for you, so you can clearly see these cysts. So these cysts are sometimes big, but don't look for too big cysts. These cysts are usually smallish. I would say when you do needle work and you put the fabric together with those little needles that you can fix it, those have usually colorful glass heads. That's the size of one of those cysts. But certainly the joint space is eroded. Here you see an intraoperative picture of a hip that was operated, and that would be the femoral head. So you see cartilages in front of you, and on top the whole cartilage is worn. It's actually bone that is exposed. And that would be a cut through it. So if we cut in the sagittal plane through that, you will see here that there are these holes inside. So a big hole would be a geode, and the smaller holes are just small little cysts in the bone. The second disease I want to draw your attention to is osteonecrosis of the femoral head. Now the old name or the previous name is avascular necrosis, but not all the causes are vascular, but it's perfectly okay to call it avascular necrosis. Now I think this is a disease of the bone because it has to do with the blood supply. So the majority of the blood supply comes from the capsule, which goes then through the capsule up into the bone and then supplies the weight-bearing area. There's a little bit of supply from endosteal bone, and there's a little bit of supply from the ligamentum teres, which is a ligament that connects the hip to the acetabulum. Now, how much do each of these give blood supply to the femoral head? The majority, 80%, is the capsule. The two others are about 10%. Now, what happens if there's a problem with the blood supply? Now, problems could be a traumatic event, it could be the alcohol, or it could be any high doses of cortisone that the patient was given by the doctor. So these are the three main causes. There's other causes as well that cause osteonecrosis of the femoral head, but these would be the three main causes: trauma, alcohol, and steroids. So what happens? The bone at some stage collapses. Now it doesn't collapse immediately. It collapses. It takes quite some time before the bone collapses, but the bone will eventually collapse. And it collapses in that weight-bearing area first. It starts off small, but then the area goes bigger, and eventually, you'll see, that whole segment collapses, but the cartilage is not so much involved. Why is it not so much involved? Because the cartilage gets its nutrition from the synovial fluid and not from the bone. So here I'm going to show you a quick video of this. So here you see the head and the blood supply. There you would see the specific blood supplies, and this would be the capsular blood supplies, and the main vessel is the posterior circumflex that comes here. And you see if that is for whatever reason now occluded, it will lead to bone death first. That will lead to collapse of the bone, and then secondary loss of the cartilage. And you see also that the cartilage is not lost everywhere, it's just in that little area there. What do the x-rays look like? Well, here you see a quite advanced stage of a bilateral avascular necrosis or osteonecrosis. And I want to draw your attention again to the left hip here. You can still see that black line that goes through there. And this is in a very advanced stage. So the black line would be the part of the cartilage that is still left in that hip. In general, on an x-ray, air is black and bone is white. The whiter the bone is, the stronger the bone is. So here's an enlarged picture of that hip. And you can see again the outline of that disease, but it moved upwards and the joint space is not totally affected. This is a schematic drawing here. So you see here the parts of the hip. You would see the joint space marked with A. You would see that top area, that collapsed area of B, and then the collapse takes place at C, and D would be again normal bone. Here would be the enlarged x-ray. You see that this has collapsed. It's not spherical anymore. The hip is not round, but you know, still looks like a bit like a hip here. And this would be an advanced stage like you've seen on this x-ray, where actually really parts of that femoral head are missing. Now let's come to the inflammatory arthritis. In inflammatory arthritis, there's practically two big groups. The one is factor positive, so that would be rheumatoid arthritis with the rheumatoid factor positive, and the other are factor negative, so there's a whole things of sarcoidosis, Still's disease, Felty's disease. So these would be all sort of like also causing inflammatory arthritis. It's about half-half between seropositive and seronegative. But in general, it's a disease of the synovium. Now here you see that yellow part of the synovium. This synovium swells and causes a synovitis. The inflammatory arthritis comes in 3 stages. The first stage is the swelling of the synovitis. You see that joint has become much bigger now, and it affects the cartilage, and it does not only affect the cartilage in the area where the weight bearing is, it practically affects it all around the joint. The second stage after synovitis leads to joint destruction. You see here periarticular erosions of the bone. And then last one comes that it gives you a deformity. Now this deformity is that the hip does not move up, the hip moves in to the acetabulum. Now why does it not move up? Hard bone moves up, hardware moves up, and if it's soft bone, like in that inflammatory arthritis, the hip actually moves in. Now let me show you here again a short little video of how this disease starts. Now you saw here the synovium. It's now a little bit see-through on this one, and you'll see that the hip is now still got good cartilage and it moves nicely. Now here you see the synovitis. It swells and thickens, and it already looks angry of this one. It destroys the cartilage to some extent, and then also causes periarticular erosion and loss of bone. Here's a typical x-ray of this. So there you see a bilateral hips that have moved into the acetabulum. Now we call this disease a protrusio acetabulum. So the hips become soft and they move inside. That obviously limits seriously the movement like abduction and adduction, and as well as flexion and extension. So let me enlarge this picture for you, and there you see how the joint has moved in. It looks not spherical, not really round anymore, and you see erosions on either side. So let's quickly repeat the main conditions. Now there are other conditions. For example, pediatric conditions, they have not included in this one. because I think they often have secondary types of arthritis. But the main three conditions are, in my opinion, easily to understand when you look at what the joint consists out of. So the joint consists out of cartilage, that's that white stuff, and then bone, and then the synovium. And each of these have their own disease. The osteoarthritis is a disease of the cartilage, that's the wear and tear. The avascular necrosis has a problem with vascularity of the bone eventually dies and the joint collapses. And this disease of the synovium is an inflammatory arthritis that comes in 3 stages. Synovitis leads to joint destruction, leads to deformity. So my advice for you, what to look at on an x-ray, first of all, look, is the joint space affected, yes or no? If it's not affected, that could be then an osteonecrosis. If it's affected, would be osteoarthritis or inflammatory arthritis. And to distinguish between those two, ask yourself, where did the hip go to? Did it move upwards or did it move medially into the joint? Thank you very much. I would like to give credit for the videos and the anatomical structures. They're from a program that is called 3D Medical. Thank you.